Good afternoon and welcome to NTV. Of course, we are disrupting your normal programming to bring you another exciting and entertaining program. Today we are talking about matters health, and the COVID-19 pandemic is posing considerable challenges for countries to maintain the provision of high quality, essential maternal and newborn health services. Now, countries grappling with the pandemic may need to divert significant resources, including midwives from regular service delivery to response efforts. We've seen that happen here, and pregnant women and mothers with newborns may experience difficulties in services due to transport disruptions and lockdown measures, or be reluctant to come to health facilities due to fear of infection. And the safest place for a woman to deliver her baby is at a functional health facility with a skilled birth attendant. However, during this global crisis, many women out there may end up delivering at home without appropriate support. Now, to help us put all that I've said into perspective, I have a panel of well-experienced people who are going to, share their views on what they have seen during, you'd say about 2 months of the outbreak of the pandemic so far here in the country. Of course, globally, could be more than 2. And I will introduce them one by one. I have on the extreme left is the spokesperson for the Ministry of Health, who joins us on short notice, I will say, and he has another engagement, so he will leave us earlier than the expected time for our conclusion of the show. But Emmanuel Aineviona, you're welcome to our studios.
Thank you, Walter. Good afternoon, viewers.
Okay, and we have Dr. Patrick Kadama. He is the Head of Policy and Strategy at the African Center for Global Health and Social Transformation, or ACHEST. Doctor, you're welcome.
Thank you very much.
And we are glad to have you here.
Thank you.
Okay, and we have Dr. Tony Kapsindoi, the Program Manager in charge of reproductive, maternal, neonatal, or newborn, child, and adolescent health and nutrition at AMREF Health Africa, also Uganda. You're welcome, Doctor.
Thank you, Walter, and good afternoon to all the viewers out there.
Okay, now, apart from my panelists here in studio, we will be joined by a couple of other people online, and these, of course, will also share their views. We have people joining us from Lira district, who are going to give us the actual picture on ground of what is actually happening. We have people who will be joining us from Kabale. So just be rest assured that this show is going to be quite an engaging show. And we also like to talk to you who is watching right now. Do send us what you think about the show, or if you have any questions, you can tag at NTV Uganda on our social media platforms, or use Facebook. Send through your question. You may be lucky that your question will be answered here, so why not? And I want us to, start at the point of understanding the impact that COVID has had on, our health systems. And of course, this engagement really is to point out the areas that we need to strengthen, because we know where we are. And to start with Dr. Patrick, as the head of policy, you're a gentleman probably who does a lot of, planning and, structures and seeing them through and how they will finally, be rolled out to the health system. What would you say on where we have come from and where we are, putting in mind that, we still have a very not so good statistic about maternal mortality rate? We still lose up to 300 mothers per every 1,000 births.
Well, it is standard teaching that when you have a pandemic or you have an epidemic, you have what we call direct mortality and morbidity. And on the other hand, you have what we call the indirect morbidity and mortality. And the policy makers are faced with the choice of how to balance the direct mortality against or with the indirect mortality due to what you would call the routine services. In this country, I've had some people call them non-COVID services. But this is really the regular services. And depending on how the epidemic finds you in your usual service package delivery, the impact on the service package will be greatly amplified if it were weak than where it was strong. So here, I think whatever we might be seeing in the system is greatly influenced by where we are with regard to our strength in delivering what we call the basic essential package of services for our population.
Okay, and what then would you make of the structures that we have in place? I know, of course, you can't say they are sufficient. Even globally, the what you'd call developed countries are grappling with, the impact of COVID-19. But when you juxtapose where we are and the structures that were put in place, what have we missed out?
In principle, you don't need new structures. We already have the structures. What we need to do is to respond and ensure that we are getting the best out of what we have before we even look for anything, etc. First, we have to identify what the essential package services are. What is a priority at all times, even during emergencies, that we must prioritize and ensure that we do not aggravate the indirect mortality while we attend to the direct mortality and morbidity of the new condition. This would be something that we have to do very rapidly early in the response. Secondly, we have to do a shift in our resource allocation to ensure that we are responding first to the existing morbidity and mortality in order not to worsen it while we tackle the new challenge. The new challenge should not come in to make it worse. And lastly, we have to have what I call strategic communication strategy to engage the public. It is the public that will win the war. It is not us in our policy chairs and in our technical positions.
Okay, you bring in an aspect of communication, and we have Emmanuel Aineviona here who speaks for the Ministry of Health. Emma, we want to understand from your side, you have really, done a lot. The ministry has been at the forefront. We've seen, figures showing the performance of the ministry in the last few days, and, it's quite a lot. But we still have some areas that, are still wanting, and that's no doubt anywhere in the world. From your side, what evaluation would you have to give to the people out there for, the missing links to access to services, especially, things like medicines not being in the facilities in time, even when the structures are there?
Thank you very much, Walter. I would like to begin from the point of communication. Communication is key and crucial for response and also during the day-to-day normal life of any public health system. First and foremost, you need to communicate the availability of the health services of which the public have to know and seek these services. So it became a little bit complex when we had now a global pandemic, COVID-19. I will begin by referring to an article which I've read in the Journal of the American Society of Tropical Medicine and Hygiene, and they have done an assessment of the response in Africa. It's COVID-19 shining a light on Africa. So among their findings, they indicated that most African countries are grappling with maintaining the non-COVID-19 services. And we are not any unique as a country. So part of the recommendation is to ensure that there is communication, to encourage all the groups and also the age brackets are able to seek the services that are tailored specific to their needs. And that is what indeed we are doing For instance, we are embarking on a mass communication campaign to ensure that those ones who need, for instance, contraceptives, family planning, continue accessing these services. But there was a disruption, I can acknowledge, in the period of March, when we registered our first case, because we registered our first case on the 21st, and also the lockdown. So we realized that there was some increase according to the health management information system. There was institutional reported deaths had increased slightly compared to the same period the previous year, which showed that indeed the COVID-19 pandemic had disrupted the access to these services. But we later on, towards the end of April, saw that these numbers of maternal deaths had begun to drop, and also mothers were given the continuous communication by the president. The mothers were beginning to go back to seek services, because at first the many seemed confused on whether even when you're pregnant, for instance, you need to still go and attend your antenatal. So when there was clarity in communication, we began to see a number, the figures of mothers seeking antenatal was also increasing.
Okay, all right. And Dr. Kadam, I'll get back to you just to give a brief highlight on, you said we have the structures available, but I was speaking to some other health experts some days back, and they were not happy with the way we are responding in this COVID-19 time. For example, shifting the emergency response systems from the district, health committee to somebody like an RDC, who is a politician, probably has no experience in how emergency systems are run. And that could be the reason why, timely responses for people like pregnant mothers or even any other emergencies are still happening, inclusive of all the measures put in place, all government cars and all that. What happens when we undermine or when we do not critically enforce or support the structures that we have in place?
You amplify the bad effects of the pandemic. So to the extent possible, as I have alluded to earlier, within the sector, you identify the priorities, you prioritize them, and you engage other sectors to move forward. If you move forward alone, you might go far, but you will not go with everybody, and things will go wrong. So as I said, Uganda was excellent in responding. Within 7 days after the pandemic was declared, we were taking very active actions here, very commendable actions. But remember, the Uganda government, through the Ministry of Health, on a very timely basis, as we got out of the executive board meeting on 29th of January, an emergency, an international emergency was declared. And Uganda had a plan in place following the 8 pillars of WHO for the control of COVID from January to June. It was on the ground, but nobody else knew about it in the other sectors. This now means that the allocation of responsibilities begin to get in disarray. Those who are not in the know will do what looks fit for them, and this might not be according to the technical plan that is in place. But with regard to the Office of Director General and his technical officers, I give them a lot of commendation on this. They have had the technical people in place, the skills, all that is required are in place, but how that then links up through the policymakers who link up with the other sectors to ensure that they are able to carry everybody with them, because most of the actions that are required in this sort of situation are household actions. They're not actions in the hospital. Washing hands, ensuring social distancing, making sure you have safe workplaces, and so on. These are all household things. They're not in the sector. So in order for them to be effective, and I think that's why strategic communication is pillar 2, to align within the national framework, which is already being, I think, amended, is being already improved upon. But you've got to have a full national plan that will get everybody moving, so that the actions that you require in the community to prevent them ending up with the disease in the hospital are actually taken forward. And this is a much more complicated situation. It took us at least 3 months to begin to engage to any extent the other sectors. So from the 29th of January, if you look at the what I have seen elsewhere, we did not actually come out of the sector until about early March.
Yeah. Okay. And Dr. Tony, I'm sure we all know here that our country still has a very relatively high fertility rate, about 5 children per woman, according to the most recent studies. And previously it was about 7, but when you go to up-country areas, areas including Kabale, I've done stories before in Kabale where a teenager has about 3 children and she wants to have another 4 children, and when you talk to them, they tell you, my parents had, we were 18 at home. So I think it's also good for me to have that number of children. But when COVID broke out, the Minister for Health was particularly worried about many things, including a baby boom, and she did warn the public that please, as you stay home, remember that you have to plan for your children. Commodities and family planning, access, and services for reproductive health, which falls under your docket, Tony. Where are we? What have you seen in the last 2 months?
Okay, thank you, Walter. It's true that when COVID-19 came in, it disrupted services. My colleagues on the panel have said already lots of things. Before I speak to this, I would like to paint a context to the viewers, because we can easily get lost into discussing COVID, which we must discuss anyway, because it's the thing of the moment. But also, it's easy to forget that the Ministry of Health has actually done a lot of good things. The government has put in place so many good things, and there is where we've been coming from. So I just want to quickly paint that context for the viewers so that they appreciate then what are the challenges that we are having. So just quickly, towards the end of 2015, we're talking about ending the Millennium Development Goals era. And so the assessments were done. And it was clear that Uganda had gained lots of successes in the area of reproductive, maternal, newborn child health care and services. So a lot had been done actually. But basing on the targets, we still had some things to do more. We're a bit lagging behind. And the ministry, together with the partners, came up with what is called the sharpened plan. That is sharpened RMN-CAH plan, which is an accelerated plan in a way to make sure that we catch up with the targets we had set. And it had very interesting strategic shifts, 5 of them. And you could read and know that we knew what we were doing. So really, I want to applaud the ministry for that, and of course the partners that work with the ministry, including the funders of some of these programs. So we were doing well. You alluded to the maternal mortality ratio, which is now at 336, and those are deaths per 100,000 live births.
Yeah.
Yes. So, and initially we moved it from 438. That was in 2011. So, 2011, 2016, it's great success. But we still have to do more, because our wish for all of us is actually to have no mother dying from maternal causes, because they are preventable. So looking at that, we crossed the SDG era, which is the Sustainable Development Goals.
Yeah.
And of course, we need to move quick with these targets again. And so we've been doing very well. And so as we've been moving very well, knowing also that there were gaps in the system, as Dr. Patrick Kadama said, this has been probably the best test of how strong our health system is. And I'm hoping that we are taking the notes and learning the lessons so that we bounce back stronger. So we've been doing well. Then COVID struck and interrupted all these things. So it is true, teenage pregnancy, for example, has been at 25% nationally. That's on average, but in some areas it's even as high as 40%. So for every 100 teenagers, the girls, you'll find 25 of that percent get pregnant. So it's not a good thing. And so COVID has interrupted some of the things: antenatal care, labor and delivery services, postnatal care. All that has been disrupted. And these have been vulnerable groups. And this plan was targeting them. So the disruption was great. And we've begun to see some of those things coming out. The PRO from the ministry talked about noticing in the statistics, the data coming from the service statistics, that there was a bit of increase in mortalities and morbidities. And that was directly linked to the disruption from COVID. So I think it is important to also note that the Ministry of Health was quick, together with the partners. When I say partners, AMREF, HS, and the others, we work together to come up with a policy guideline to ensure that there is continuity of services. And that policy is in place. The question is, have we implemented it to the dot? That's something that maybe, given the nature of the crisis, when we talk about 2 months, it's like short, but it's like also not favorable time to have this policy implemented. Yeah. So I think the response has been good. No doubt the antenatal care services, labor and delivery, postnatal, family planning services, and other related health services have been disrupted. And we have evidence here and there coming from where we are based as programs. For example, in AMREF, we are in about 47 districts. So we pick these stories and we see these gaps and challenges coming out. Yeah. And but the response has been fairly well, and we can do more together.
Okay, so speaking about evidence, we have Dr. Ochen from Lira Regional Referral Hospital, and we spoke to him about, the situation at the regional referral, the fact that they are also dealing with COVID-19 patients. We remember a scenario when NTV, NTV Grade B Hospital was dealing with COVID-19 patients. They had to stop some services, and which now became a danger to the people surrounding that area. We had some people who couldn't access, other services, people with non-communicable diseases, people with children. So let's see what Dr. Ochen said earlier when we had an interview with him.
There has been issues of lockdown and ban on the use of private and public means of transport. For instance, border not carrying people, and then the use of public transport and private transport. It actually put a huge burden on the resources at the district health office. Aware that many of the mothers who are pregnant, whenever they would need service, they would either access the next level of care using borders or another private or public means of transport. But now when there was a ban, all these demand had to be borne on the resources within the health department of Lira district. I am happy that, yes, our chief administrative officer allocated in my department a number of vehicles to be used. We had to train ourselves in providing this service by allocating fuel from other vote functions. So support supervision had to be called off because we used to move a lot in health facilities doing support supervision using the fuel that had been allocated to us. But we had to shut it down and then focus purely on maternal and child health services, ensuring that whenever a mother is pregnant and is in labor, maybe calls from the level of care, health center 3, and needs to be referred maybe to health center 4 or hospital for cesarean section. And it is true that not only issues of transport, but even the human resource. Many private health facilities scaled down on their functionalities, aware that there was social distancing, but also limitation in the use of public transport, which they were using for accessing their facilities. And because of that, the burden of health services had to be on our public and private not-for-profit healthcare system. And so you find our health workers are busy working and they're having huge volume of patients in health facilities. But I'm happy that yes, with the involvement of partners, we have been having additional support in terms of fuel, because the biggest challenge has been fuel. We needed to always pick patients from various localities, from communities, and bring to facilities, mainly medical emergencies, and even execute referrals to the national level, that is the Mulago National Referral Hospital. And so COVID-19 has called for need for additional resources, especially in terms of logistics. We are looking at the consumables. If you get to gloves, if you get to other drugs, you realize that the demand for gloves and other personal protective equipment increased, because now that there is COVID-19, our health workers have to put on face mask. You don't need to take chance on a patient who is coughing. You must be on gloves, unlike before, where each time you are examining, sometimes when you are talking, you're not on a face mask, but every day you must be on a face mask. And the demand for PPE is increased, and that still constrained us on resources. And we are also seeing that whereas we have been talking about mitigating the challenge of referral of pregnant mothers to health facilities, but other service components like immunization have also been compromised. You could be aware that in every healthcare setting, especially now with our private, not-for-profit and public health facilities, whereas we have static immunization services, that is services within the health facility, our health workers together with the village health teams would move to outposts in gazetted places, either primary schools or marketplaces or in a community hall, and they would carry out routine immunization in communities, reaching mothers with these services. But unfortunately, with the lockdown and with the ban on the use of public transport, and even saying that if you're using a motorcycle, you must not carry yourselves, then many of these services were paralyzed. So our healthcare workers cannot easily access the immunization outposts because they used to carry themselves on the motorcycles that have been given by Gavi. But unfortunately, because of this, they needed to move along. But also within the health facility setting, other service components, the demand increased. So we will find that it has affected our immunization services greatly. The performance on immunization in all the health facilities in Lira has come down purely because of the lockdown. When the lockdown was just started, we lost about 2 mothers. One of them accessed the health facility when it was late, and she reached, and she was already bleeding profusely. That was in Aromo Health Center 3. And on arrival, she pushed and died. And unfortunately, that was one mother. And another one also, it was purely related to late referral, late access of healthcare facility. But I'm happy that we presented in our task force meetings, and the regional police commander, together with the security team, agreed that yes, whereas we are talking about limitation on the use of public transport, any border cyclist, any vehicle carrying a patient, even if it is a private vehicle, must be allowed to move and deliver that person to the hospital. So since that time, we have not lost any mother. I am happy that yesterday when we were looking at our dashboard across the country, Lira district is not among the districts in red. which have lost mothers due to pregnancy or another complication.
Okay.
So we mitigated that challenge by allowing the use of private vehicles and motorcycles and any other means of transport to carry any sick patient without any problem. And that one was granted by the police, and we are happy that it is still working on very well.
Okay, what's the status of reproductive health services, for example, for adolescents?
Oh yes, the status of reproductive health services, we are looking at the reduction in access to reproductive health services. Just 2 days ago, I was with the Reproductive Health Uganda, that is a partner which is working within Lira district, and they did cervical cancer screening as an outreach, and I was there myself to ensure that there was social distance. But you can imagine one radio call message that was passed on only one day attracted more than 500 mothers coming for cervical cancer screening. That shows you that the demand for the service is overwhelming, but unfortunately, these services are not readily available. So this has been compromised because we are looking at reducing the number of people crowding to access services.
Okay, that is Dr. Ochen Buchan, the District Health Officer for Lira Regional Referral Hospital. And we have Dr. Peter Waiswa from the School of Public Health at Makerere University. He is going to be joining us shortly after the break. Welcome back. We are still, having a conversation about strengthening our health system. And of course, the focus today majorly will be about maternal health, child and newborn, reproductive health. And of course, the ripple effects, affect everybody and the entire population. And, if you've followed the trend of the population of the country, you will get to know that we have more women in the country than men, which, needs to be something that we need to follow up critically well. And we are joined by Dr. Peter Waiswa, who is an associate professor from Makerere University School of Public Health. And he does a lot of work in health policy planning and management. Doctor, can you hear us?
Yes, I can hear you. I hope you can hear me.
Okay. All right. So, Doctor, we had an engagement with the district health officer from Lira Regional Referral Hospital, and part of his sentiments here and there, about this whole period is that the provision of protective gear to the health workers there, is making the health workers stay away. And this is a comment that is raised by several people. I spoke to other people who will be listening to their voices from Kawale, who raised the same issue. In terms of planning and managing our health system, what do we need to learn from this time around?
Yeah, thank you so much. First of all, I would like to congratulate the Minister of Health for what they have done so far and most of the government. Up to now, we've not lost any COVID cases, but unfortunately, the reality is we are having excess mortality in the country. And there's been so much focus on COVID, which is understandable, but of course we must also consider other services. Now, when you talk about PPE not being available, I would like to comment on these issues from the perspective of a health system, because we look at a health system as having various building blocks. So the issue of PPE is what we call commodities, which also includes medicines. And definitely in a pandemic like this, the health workers must be protected. That is so important. Now, the government has been trying to scale up availability of the PPE, but certainly in many places, including actually in Kampala, in Mulago, health workers are complaining that these are not available. And I think they've been disrupted because many of the things we have to import. Now, COVID-19, for me, I'm looking at it as a sort of a wake-up
Yes, doctor, we can hear you.
Hello? Yes, although we have a pandemic impacting the whole world, so far in Uganda we have had no deaths, and the disease has been mild. But on the other hand, it has checked our health system. So far, we've been actually in Makere, we've been working with the ministry and UNICEF and monitoring the continuity of services. And we see that across the country, for mothers, for newborn, for children, services have been interrupted. There is also, we've seen an increase in mortality in some aspects, especially for what we call perinatal, those are newborn babies and stillbirth. We've seen an increase in babies born low birth weight. We've also seen an increase in malnutrition. So then what does Uganda need to do? I think we need to be more prepared. Right now, I think we have gone through what I think is phase 1 of the pandemic in Uganda, in which we started by those cases that were importing, and the community infections seem to be with us. So I think although we have panic, we need to step back and see how can we integrate the control of COVID and integrate this in the maintenance of routine services. You know, if we send out health workers, if we train them on COVID, can we also train them on immunization? Can we also train them on better care? Can we have the supplies? Actually, on a positive note, the government has assured that the medicines are available in hospitals, and there is quite a good supply of routine medicines. But how about PPE is not enough. The other issue that we have is actually the issue of increasing number of cases that are in hospitals, especially regional hospitals. And because these cases are in hospitals, people are sort of panicking, both the health workers, but also the community. And it has led to a reduction of the number of people seeking care. They're coming only in emergency services. So I think one of the important things is to go back to primary care as a foundation. And indeed in Uganda, in terms of policy, but also in terms of practice, primary care has been a major focus. But communities must be brought on board. Just like Dr. Kadama said, that the people and the communities must be brought on the board so that we start sensitizing people on how to take care of themselves at home, but also how do they access care in the facilities and how do they do prevention. This is what we call resilient community health systems. We must have resilient community system. The second thing which I would like to call upon the government, and they are trying to do it, but I think chronically we've had very limited resources that are sent to districts. And now districts are taking care of COVID cases and COVID programs. But the resources they have, both in terms of human resource and money, is so limited. In our assessment, we found that actually the fragmentation of money, the money does not directly go to the district director. It goes through the routine district system. But this being an emergency, I think it is important that the resources are sent directly to the district health officer. And then also the issue of in future, right now, we don't have all the supplies we need. It is good that some industries have stepped up and they have started producing commodities, but I think this is also a lesson to learn that Uganda must become self-sustaining. As you know, at the beginning of COVID, almost all Western people are packed and left, and they left us, meaning that one of the key lessons, we must be responsible for our own systems. That will include us recognizing that actually human resources and also the health of people are perhaps the most important national resource we have. In fact, the World Bank calls it human capital development as a foundation of the national development. So one of the calls I have is, can we learn from COVID and have more resources to the health system in Uganda? The other area that we need to be working on so much is actually the information system. Good enough, COVID found Uganda when it was a bit prepared in terms of surveillance. And the president has been talking about these hubs that are over 100 where they collect information and they can take off samples and test for COVID. But I think the information system that shows what is going on in the community Right now, it seems so many deaths are happening in the community, but we don't have this information. This is an area we need to work on because information should be the basis of the response that we make as a country. So these are some of the issues that we need to be focusing on. And I think back to this country does so well when we do things what we call vertical programs. So vertical programs, there are programs in Uganda like now the pandemic. It is being decentralized now, but most of its management is vertical. Vertical programs like HIV, HIV has special financing, immunization has special financing, and the malaria. Those programs do well, but when it comes to some of these, can I call them the poor diseases, like maternal newborn child health, then this program tend to suffer. Right now, we have an estimate of about 74,000 children who die a year, or actually more than 200 a day, and about 16 mothers a day. Now, in the pandemic, this condition might be increasing. So these are some of the issues that we need to be attending to as we continue learning about COVID and how it affects our health system.
Okay, Doctor, you do quote, some, you say we have seen an increase in mortality. I just want to be clear. Is that some kind of study that you have undertaken yourself, or are you quoting from, any known study that we can, access and use? Just for clarity.
So good enough, the government is actually monitoring the services. And the ministry, there is a committee which is called assessing the continuity of services and the response that is made. Now, from this, we've seen that for some programs, there has been interruption. So this is from real data that is coming from the health system. But over time, it seems the response is actually improving, and the mortality is beginning to come back to the average one. But at the beginning, apart from those reports that you people are making in the media, these are backed up by real data that initially there has been an increase in the mortality for maternal health, for children under 5, and for newborn babies, and also an increase in malnutrition. In places, actually, some of this area we've looked at where malnutrition has actually increased more severely, places like Karamoja. Then in terms of babies being born underweight, some areas in Western Uganda. So this is real data, but good enough, I think the system is trying to work on how to respond. And it's not surprising that, of course, there will be an increase in mortality given the interruptions in services. Even the Lancet and UNICEF made an estimate that if services reduce, if immunization reduced, if malaria control like use of bed nets are reduced, if immunization reduced, if deliveries in hospital, they have actually gone down a bit, then would we expect a proportionate increase in the mortality. And these are the things that we must respond to right away and avoid a catastrophe. So COVID has not killed people directly, but it's actually having a negative impact on the population, especially among the poorest.
All right. Instead, the picture that you see on the side is Dennis Chivira, who will be speaking to us also later on in the show. He's the Executive Director for the Coalition for Health Promotion and Social Development, or HEPS Uganda. But I want to take this straight to Emanuela Ineviona. How do you respond to Dr. Peter Waiswa's comments? He says we've seen an increase in mortality rates, and he even projects that we will have issues to do with malnutrition later on.
The Ministry of Health is cognizant of all these arising issues, and right on the onset we had to sit and plan, and he has alluded to the committee that was put in place to ensure continuity of services. So we are looking at the data in terms of the trends using our health information management system, and also prescribing the solutions. For instance, we had to look at what are the delays that are occurring due to the impacts of the pandemic. For instance, movement of health workers to the hospitals, movement of patients to the hospital. That has by and large been addressed, and we have seen now easing of the lockdown that has brought back some sense of public transport. So we know patients who are experiencing any challenges will be able now to move to the health facilities. We also looked at another critical aspect, which is blood. Blood is one of the essential commodities that is needed during emergencies and also for maternal and childbirth. So we are addressing the aspect of ensuring that we have enough blood to give to any patient who might present with need of blood. We're also looking at what he referred to, the personal protective equipment. The personal protective equipment, as you may be aware, globally has been a challenge. Even for first world countries, there was a time I read, and also the United Kingdom was looking at how best they can use their personal protective equipment sparingly. So we have put guidelines on how to use this PPE. Of course, the fear, the stigma that comes with the pandemic like COVID-19, everyone in the health facility now needs some form of PPE. But what I can tell you is that PPE are components. They are components of PPE. An N95 mask is part of PPE. These gloves people put on are part of PPE. But not every health worker at the moment needs a full suit of PPE if you're not directly in contact with confirmed cases of COVID-19. However, we continuously avail this personal protective equipment to our health workers based on the availability from our suppliers. And in the past whole 1 week, the National Medical Stores has been making deliveries of this personal protective equipment.
Okay, we will be talking to Dennis Chivira because he's been doing a lot of work in trying to, put the figures together in terms of access to medicine specifically. But are you tracking, as the Minister of Health, all these things therein between COVID, numbers of people probably who are likely to suffer from malnutrition?
Yes, indeed, we have departments of community health. Community health, that is where the nutrition division falls. There is a team there, they are doing some work to assess nutrition needs. We have even had the challenge with the desert locusts. That is also going to cause impact on the availability of nutritious foods. So the teams are working at a multidisciplinary level to ensure that we get this data. And at time why in the future we shall be able to make reports and assessments based on what these teams are observing. The same to do with mortalities. We will need to have in our annual sector report, and that is where the journalists would come in to make a comparison. For instance, the situation in our previous annual sector report, because it captures hospital deaths, it captures admissions, it captures various mortality rates, and also that would be to compare how did we perform during the period of the pandemic vis-a-vis the normal times, for instance, last year, 2019. So I expect that our teams will give us good and accurate data that we can use. But at the same time, the policymakers are also doing their job to see how best we can adjust the programs we are implementing to ensure that all the gaps that might be arising are fixed. And that is what indeed the Ministry of Health teams are doing. Dr. Kadama talked about the delay to have a multi-sectoral approach to the pandemic. That also was a challenge, because at first it seemed to look like an all health sector fight, yet indeed it was an all sector fight. But we have seen each each sector of the economy, each department of government doing whatever it is supposed to do to supplement the efforts by the Ministry of Health.
Okay, so when you talk about evidence and juxtaposing facts between this period and the previous period, yes. I spoke to Tumhire Florence, the Executive Director, Kabale Women in Development, and she gave, some data from Kabale in comparison. So let's take a look at this video. We have Tumhire Florence speaking about the situation in Kabale.
You cannot reach probably to hundreds of thousands of our people directly. But once we engage like this, we then air out some of the issues that are affecting the people, the status of service delivery in our domains, and how all of us are partnering and collaborating to ensure that lives remain safe and people continue to live their lives and make contributions.
Okay. Florence is back, and this time with a very stable picture. Florence, we will come to you to give us a picture from your end, but Ongom here, was telling us the mandate of, civil society, which really is working together with government, and it is key in, provision of services in reproductive health, maternal, child, and newborn health. And Ongom, all right, okay, so he's preparing. Okay, so Ongom, you can hear us?
Yeah, sure.
Okay, so what is the situation like in Lira when it comes to, access to these services, reproductive, maternal, newborn, and child health services?
Yes, thank you, Walter. Just like the rest of the country, got into lockdown from around mid-March, the world has undergone a terrific transformation within the last few months. The situation is quite intense, of course, with the first cases being reported, the news globally, people were drained into fear and all sorts of anxiety. And therefore, for example, the service delivery, because we didn't know how to deal with the disease, people were talking about social distancing, which nobody knew. Everybody had to cow out. People ran back to homes. There are those who have actually moved from the urban area back to rural because, the situation in towns, just like we used to talk of rural urban, this time it has been urban to rural migration. People went back to engage in agriculture and other services. So in terms of health service delivery, you will realize that because of the lockdown, the return of all the children at once, the population concentration increased virtually in all areas, and they have been, more terrible in rural areas. Why? Because, if people were doing business, moving up and down, you would have not such, a number of people at the same time in the same location. The same thing has happened in every household, in any family in the country and globally. And therefore, there has been increased demand for services. At the beginning, as we assessed, people had run away because they didn't know what to do. Everybody was very much scared. So the services had actually slammed. The people were not going to the health facilities. People were fearing one another. But as messages kept running, by government, Ministry of Health, civil society organizations, different stakeholders, people have returned. And right now, our assessment is that people are accessing services. Now, for the situation in Lira Regional Referral Hospital, you know that government designated the regional referral hospitals to be able to provide, services in terms of COVID response. And therefore, some of the OPD sections were partially closed down. What it meant is that people used to be referred to access services from Lira Regional Referral Hospital. And therefore, now they needed to find alternatives. For example, we have within the municipality about 4 health facilities, let's say at Health Center 3 level. We have a Bear Health Center 3 that used to actually serve about 20 or so thousand people. Right now, they are reporting serving more than 45,000 people. The facility is in a small space. The question of distancing, social distancing is an issue. In terms of staffing, they should have had 19 staff, but they have 16 because 3 additional staff were sent to another facility, level 3, which has not yet been, level 2, which has not been coded, that is a DL, because they borrowed from some 2 facilities. That's the situation, and it has not happened because of COVID. It was happening. I hope that government will be able to code a DL L Center 2 into 3, because now Oper is overwhelmed with a lot of service demands. The people are coming to a place which cannot house that number.
The situation in Kaware is not far different from any other district at the border, but let me give you the picture of Kaware. When the public transport and the lockdown was announced and the restrictions on movement, including curfew, were put in March, Kaware is one of the districts that suffered, had immense effects, because even in Kaware, we have a geographical coverage where health centers are located in hard to reach areas, like on mountains, on what. So when the pandemic came and the restrictions on public transport and the movement were put, the mothers, I might say, were the first victims. Not only mothers, but all clients on family planning were affected because they could not access health facilities to get like family planning, their family planning refills. Mothers could not access antenatal care services, and mothers could also not access postnatal care services because of the ban of the public transport and the restrictions on transport, including the curfew and lockdown, where everybody was supposed to remain at home. So this one affected sexual and reproductive health services, and the numbers dropped on all indicators on sexual and reproductive health services in Kaware district. I can give you a picture of how the family planning dropped on all the indicators, including OPD attendance. Yeah. In January, we had 30840. In February, 32166. In March, 32228. And in April, we have 23932. So you can see this indicator also on OPD attendance, which means that the affected was not only sexual and reproductive health services, but even access to other services. Then on first antenatal visit for women, in January we have 978. Then in February we have 9,009. Then in March we have 913. Whereas in April we had only 727. So it means are not attending the first antenatal. And Mr. Walter, you know what it will cause. If mothers are not attending antenatal, it means they are not prepared to have a clean and safe delivery. And what will follow are the fetus, where we will lose mothers and children during labor. Then on the 4th antenatal visit, it also dropped. In January, we had 497. Then in March, we had 418, but in April, we had 390. It means on that indicator, services is also flowing down. Yeah. Then when we reached at deliveries, in April, we had 770. In March, we had 777, whereas in April, we had only 590. So it means the biostatistician is still compiling the data for May, but the indicator is continuing to slow down. Then when we reach that postnatal, it is the indicator is not doing any better. In March, we had 1,360, and in April, we had only 11,062. So it means on all the indicators, service uptake is falling down. Then on family planning users, we have a total of 2,251 in March, whereas in April we have 2,248. So you can see how sexual reproductive health service uptake has slowed down due to the lockdown and the effects of the pandemic. So when you go to access to other services like antiretroviral and other chronic diseases, the situation is not any better.
Okay, so that's Florence, and you know, she could go on and on and on, but of course you can see that the figures really were showing, you know, there's a decline in the service uptake. We still have Chibira online, and I want us, you know, to hear from him about, you know, the access to essential medicines. What have you been gathering on ground?
Thank you, Walter, and good afternoon to the viewers. I'd like to start by painting a global picture of what's happening. Of course, with the coming of COVID-19, we see that health systems globally were not really prepared to fight this pandemic. We saw disruption of production and supply chains. For example, in March, one of the biggest manufacturers of condoms in Malaysia, the plant closed down. We also see a rush by the richer countries to try and ramp up production of medicines, import what they do not have, and also, of course, the discussion over the vaccine. We're all following that. A clear example is when President Trump decided to divert commodities that were headed, I think, to Canada. So that rush shows you exactly what's happening, and certainly will come down and affect us. We also see that with the closure of international travel, that there are issues. Although cargo planes are still moving, a cargo plane will, it now costs about four times the amount it used to cost to move goods to Uganda. Of course, that impacts on the overall price at which you will get a commodity, and therefore it reduces the overall quantity that one will get. But also, with COVID-19, every medicine or commodity that was used in the medicines to treat this disease, we saw that all those commodities, the prices skyrocketed. I'll give an example of hydroxychloroquine, which was, of course, also made very famous by President Trump. The active ingredients, pharmaceutical ingredients for this commodity, once it was known that it's being used in the management of COVID-19, really went up. A kilo of active pharmaceutical ingredients for this, which is also used for chloroquine, moved from $15 to $300, which is 20 times over. And of course, there were people willing to pay much further. That means that if there was manufacturing done in a country like ours, we would have to get the commodity at a much exorbitant price we may not be able to afford. But also the development partners that are supporting the government were impacted greatly. The International Planned Parenthood Federation, in April, it announced the closure of 5,000 of its outlets, and these are the outlets that provide sexual reproductive health services, and 100 of those were actually in Uganda. And this meant that 10 million vulnerable girls and women globally would go without contraception. That certainly has implications to the health of, even here in Uganda. One of the other issues we have as a country is that there is an over-dependence on donors. If you look even at the fight of COVID-19, we've gotten a lot of loans, but also grants from well-wishers out there. And certainly, of course, whenever something like that, whenever there is an issue and the donors pull away, certainly access to health services will suffer. In Uganda currently, about 85% of family planning services are provided by donors. 90% of antiretroviral therapy is also provided through donor support. About 80% still of anti-malarial treatment is from donors, and so any kind of disruption will have to impact on access. Therefore, the issues we are hearing about stockouts in some places, these are issues we'll certainly expect because of what's happening globally. But also we see that uptake in some places has been impacted. I've been informed that in Kamuli they are struggling to get women to give birth from health facilities because, of course, the added costs that come besides the costs of treatment. People will need transport, which is not readily available. People will need to buy masks. But also, let us not underestimate the issue of food. You know, food is one of the most important determinants to health. Without food, people are not going to be able to invest even in health. And so this current pandemic, what it's really shown us is that we have to look internally. What we could do is really to invest in local pharmaceutical production. We know that we have capacity here in country, and if supported, these industries can produce. And the opportunity is that the pharmaceutical industry is a very rich industry here. It's valued at more than $400 million a year. And the local industry does not even account for 10% of that. So just imagine if we were able to produce locally and took up a big chunk of those medicines, produce them internally, and that would have a trickle effect on many, many other sectors in our economy. So, Walter, over to you for now.
All right, thank you very much, Mr. Chivira. He's the Executive Director at HEPS Uganda, and of course, he's been, trying to find out issues of supplies, especially for essential medicines. Emma, I'll pick your parting shot because I know you want to leave us, but you've had some of the issues that have been pointed out there. Continuity of services, of course, they will never stop, but how do we remove or how do we eliminate, some of these small issues that always arise? Issues like supplies when medicines are there. You've had the DHO from Lira saying they've not had medicines, essential medicines, for up to 3 weeks now. Those are small things that could be dealt with. And financing, isn't this the time that you advocate for the 15% as, ratified in the Abuja Declaration?
Yes, indeed. The government has been, for some time, trying to ensure that the health budget is a bit sufficient compared to other sectors. But we still have a lot of gaps also in infrastructure development, also power generation, and there have been a lot of investments as far as the infrastructure development. When you look at the national budget, the transport and work sector tends to take a big chunk. So hopefully we shall be able to have all those infrastructure developments done on time, and also now have the required focus that is needed for the health sector. Dr. Kadama will agree with me that we still have gaps as far as human resources for health is concerned, but there is an effort that is deliberately to ensure that health workers, we increase on the number of health workers per the available gaps, as per the available slots in the public service, and also to ensure that we retain the health workers, because we've had also some who have gone abroad for greener pastures, and that was largely attributed to challenges and lack of adequate medicines, lack of adequate infrastructure, which government has concentrated on. When I talk of infrastructure, even health infrastructure is all inclusive. Like the refurbishment of the Murago National Referral Hospital, the coming up of the Women's Hospital, and also the pediatric specialized hospital in Entebbe. All those ones require human resources. When I come back to the pandemic, we've recruited about 500 health workers that include doctors, nurses, and midwives, and also other critical cadres. That was also partly to address the challenge of human resources. What the ED of HEPS has raised is that we need now to look into local manufacturing, as the president's call also has been, moving away from importing to having most of the products we use here in the country manufactured in Uganda. I can make a case study of the availability of the sanitizers. Around March, a sanitizer had become almost the most expensive commodity on the Ugandan markets. But now everywhere you go, these brewery farms, companies and factories had to readjust and had to make sanitizers, and the hand sanitizer is not an issue. The same to do with face masks. We've had companies locally make medical masks, and now we are even going into the manufacture of non-medical face masks, of which government also intends to distribute a mask to each Ugandan who is 6 years and above. So this COVID pandemic has given an opportunity to have the healthcare system get better, and also help us prepare for other similar situations. Because when we talk about equipping the regional referral hospitals with ICU beds, with ventilators, having a fleet of ambulances, making an addition of about 55 ambulances, that is going to have, going forward, it will have a sustainable impact on the healthcare system in terms of better outputs. My prayer is that I hope these investments are maintained and looked after very well by the users who are the health workers. So this pandemic, we have the fight on, and we hope we'll be able to defeat it and not to really largely disrupt the other health services. My appeal is to ensure my appeal to the population to ensure that if you have a non-communicable disease that is chronic, you need to always seek your medical treatment, have your drug refills. The same applies, for instance, to persons living with HIV and also tuberculosis, to ensure that they have their drug refills, have consultations with their doctors. The issue of malaria, we need to use very well our mosquito bed nets to ensure that we prevent ourselves from mosquito bites, and also maintain this culture we have been, the new normal of hand washing and good hygiene and personal hygiene, because this will come a long way in preventing a number of preventable diseases.
Okay.
I would like to stop there.
All right. Thank you very much, Emmanuel Aineviona, the spokesperson of the Ministry of Health. And of course, he will have to leave us because he has another engagement to take part in. But we do appreciate your time here. And if you have just joined us, we are still talking strengthening our health system. And, you know, largely today's focus is on reproductive health, maternal, newborn, and child health. And we have experts from various fields. I like what Dr. Kadama told me before we went on air. He said he is retired and he's now a consumer of the service. And, you know, before he was in the service. Doctor, when you say that, it means that you have actually, looked at the entire service from, you'd say top to bottom, being part of it and now actually consuming its services. What do you see as the post-COVID-19 period, and how should we prepare to deal with it?
Thank you. What will be critically important moving forward is to address the weaknesses we have unveiled as COVID came. The pandemic unmasked a number of issues. It's been talking about PPEs. To me, PPE is not an issue brought by COVID. No, it was simply accentuated. A government assessment we had on radio and TV showed that, in fact, the situation was 10% in the system. That was not brought by COVID. That is where we were. We had a great shortage, such shortage that even mothers in the village, they don't even have to listen to us. They know if you are going to deliver, please take your own cotton wool and go with some gloves, otherwise you'll have a problem where you are going to deliver. This is now common knowledge. How do we get out of this? First, let's make sure we have the people to respond to what the public wants. And making sure that the health workforce is well organized and deployed at the front line. Secondly, that the health workforce has the tools to do the work. That way we shall be responsive. The technical way of describing a health system stresses what we call the supply side, the 6 building blocks. But anthropologically we know health system is a social construct. Is to do with the beliefs and behavior of people to seek care. And therefore we have to first and foremost respond to what people wish to do in order to remain healthy. And therefore we will have to make sure that we engage other sectors, that we build the coalitions that can galvanize households to engage in what we are calling good hygiene. Good hygiene is not in the hospital, it will be in the household. They must have good nutrition so that their immunity is properly built up to fight new diseases. They must have better hygienic conditions so that they are able not to catch new infections in the workplace and other places where they are traveling, but also in the household. A minimum basic package will have to be in place if we are moving forward. We must work in every way possible to put it in place. This will be the foundation of new funding mechanisms. To try and drive new funding mechanisms such as health insurance, when this is not in place, they will not plug the gap. They will not build the capacity for you to move from 10% to a better level of PPEs. They can only assist complementarily from the public action that is available for us to move forward. And that is focusing on ensuring that we have available to us a public package that all have access. Everybody has talked about public transport having been somehow stopped during this period. 1991, that is the last century, we used to look at access to services. We called it walking distance. So we would measure the population that are within walking distance to their frontline level services. Today, because of better transport, I think people don't pay much attention to this. We have a wake-up call. You may have to walk to your healthcare facility either to deliver or to take children for services or to access any other emergency that will be. COVID has shown us that the very next service that you require should be in walking distance before you are referred for any further services anywhere else. And if we do not get this lesson now, we will continue to have the shock that we are now recovering from.
Okay. Dr. Peter Waiswa, I want to take your parting shot before I return to studio. And, you know, the fact that you've done a lot of work in management, do you see this as a problem with the way we manage our systems? We have, you know, at least some systems in place, but the way we manage it to ensure that we actually have enough health professionals on the front line, you know, ready for anything. I was speaking to Dr. Kobusinje, Olive, and, you know, she said to her she's not pleased the way we are just guessing on what we want to do, you know. We think that we are going to put up a tent that will require, you know, certain numbers of doctors. Is that a problem of management, and how do we handle?
Talking about especially maternal newborn child health, recently we did a study, it was funded by USAID, and we're looking at over the last 10 years, how has been management and coordination for maternal newborn and child health services in the country. And what we found was actually that there is a lot of fragmentation. You know, the Uganda health system is so complex. They describe it as almost more than 50% private. There is also the informal and, of course, the public. And there are so many levels, too many actors, and there is actually, of course, we've had this thing of new districts, and then the too many actors, community workers in the thousands. So it is one of the biggest challenges we have in the country is actually the governance of the system. And perhaps that is actually the weakest part of the system. Because in terms of infrastructure, we hope we have the infrastructure, although it is poor quality generally. And so we need to improve the way we manage, we organize, manage, and finance the system. The other one is this is a health system which has too many actors, donors especially, but also NGOs and CSOs. And we've given them a lot of roles, but how is their coordination? And who assures that they are accountable, that they work effectively, and there is value for money for what they have? So I think as we continue strengthening the health system, the starting point is actually in the management and the governance of the health system, on how it is organized, how services are delivered, and how accountability is done. That will be a starting point at all levels. Right now, it is almost impossible to do. The Ministry of Health is no longer able to supervise all the entities. And right now, they are trying to move into like a regional system. But as we know, per policy in Uganda, we actually don't have regional administrative structures. This role is being given to regional hospitals, but they are not able actually to coordinate all these services in the region unless their public health departments are strengthened. So management is a critical and important part, and perhaps we must reduce the fragmentation. And if management is weak, then it means that even the resources we put in, the health workers, the medicines, the equipment, the buildings, all will not be optimized in terms of utilization. We cannot get the best out of our services. And you can see it, that those services that, as I said before, that are vertical, like a bit of HIV, immunization, malaria, and now COVID, they show as if we are performing very well. But when we come to these services, which should be routine, which we all need every day, we perform quite badly. So I think I agree with Dr. Kobsinje that this is an area that we need to work on and strengthen the system. So those are some of my comments about the management of the system. The other one is actually the way we prioritize. And in Uganda, there's been this big debate about infrastructure, all these things. But I think, as I said before, COVID is a major wake-up call. It has shown us that the human beings and the people and the health of the people and the system that delivers that health, which is the health system, is our number one priority, and we must invest in it. In fact, the more advanced countries measure their development in terms of the human capital development, and that is also what the World Bank, and indeed, the whole thinking about the SDGs is about that. Go beyond the mortality, go beyond the money that the system produces, and look at the health of the people. Do they thrive? Do they transform? Are they productive? So those are some of the things that I wanted to say in terms of how we should be going forward. Then getting close to the people. Agreeing with Dr. Kadama what he said, that the people should be at the center of the system, also the center of this COVID control. How are people participating? I think this process of thinking that, of course, the ministry or the government will deliver and we should be waiting, I think cannot work. We must go and engage the people and see what is the best way to manage this COVID. If you walk around Kampala, you find that compliance to some of these COVID control measures is so limited because I think we are not listening so much to the people and see what is their concern, which for me caused that, as I said before, the data and the people from those who called from Kabale and Lila and even the spokesperson of the ministry confirmed it, that we are seeing increasing vulnerability, especially among certain groups in rural areas, but also in urban settings. We must identify these vulnerable populations and support them. And the support is not just medicine. And actually, when we talk about health system, we talk about not just the clinical services, not just the public health, but all these things that support the community to be healthy. That includes the sanitation and issues like that. So we must identify those vulnerable people and ensure that they are supported and so that they don't really become worse, as we are seeing right now. Over.
Thank you very much, Dr. Peter Waiswa. And of course, we will, let you go for now. Thank you very much for your contribution to this engagement. I will turn to Dr. Tony here. Dr. Peter raises issues of fragmentation of duties with the Ministry of Health. And we know that advocacy is key, and working with partners cannot be excluded as regards developing countries and building their systems. But how should we use this card of advocacy, and ensure that we are not doing fragmentation like he's saying, or we're actually not doing what the ministry is already doing?
Okay, thank you, Walter. I think there was something in that line, only that COVID has come to interrupt. I know this is very important because there is the PPP, the public-private partnerships, and that's something that the ministry encourages. That's something that we all would like to see. Perhaps if there is anything that COVID-19 has taught us, then it should be that we cannot do things on our own. We need to work together. We need to embrace partnerships more because there is a synergy that we attain. Partners bring in different strength, bring in different resources, and also different skills and knowledge abilities. There are those in research. They give us the evidence to base on to do proper planning. So I think the Ministry of Health has been doing well because there has been a lot of technical working groups happening before. and they continue to happen. What maybe we just need to do is not to drop the ball, because it's been there. We just need to carry on doing that. And of course, it's been difficult in the panic mode that we've been in, but we need to sober up a bit, appreciate that COVID is here to stay. So we need to balance and handle COVID, plus also the demands of the other, disease or conditions that we need to attend to, the reproductive, maternal, newborn child health issues, up to nutrition and the others. Malaria, for example, kills 16 people per day here in Uganda. That's something that is, if we say it, it should actually scare us. 16 per day. And that's from documented evidence in the health facility. Some even go unnoticed. The maternal mortality ratio, if we break it down, I know we talk about 336 per 100,000 live birth. But if we make it simple, we could talk about probably 14, 15, 16 people per day. That is, some people have used this before, that is an equivalent of a taxi full of women dying per day, which is huge. So these issues remain. The ministry and partners need to work together. We know the coordination role is from the ministry. And I think it's up to us, the partners, AMREF, ACHEST, and the others, to be more supportive to the ministry, because I know they are receptive.
Yeah, and well, probably one thing that we also need to, listen to is that COVID actually has also disrupted these partnerships, where you'd think that you'll be getting support from them. They're actually also trying to support their own systems. And this will in turn lead to a break in continuity, which is very key for our systems. Is there a way that partners and the Ministry of Health draw plans for the future?
Yes, there is. Walter, there are platforms that are actually in place for the Ministry of Health and the partners to work together, including development of actual guidelines, service delivery guidelines, policy documents. I know we are talking about right now the National Health Insurance Bill. It has been circulating in the partner space platforms for their contribution. Personally, I've seen it, and also I've had a bit of contribution to it. So platforms are there. My appeal is that we need to utilize them, even in the midst of the current panic that COVID has brought in. And of course, you had asked earlier about advocacy. I didn't probably complete it. This is the time for advocacy, to do it much more. And there is no better way to do it than a joint, amplified voice, using the partnerships again. So I think, advocacy is very key in this time, and it's important to sit together and plan jointly together.
Okay. All right. Dennis Chivira is still online, and we will take his parting shot at this moment. Dennis, what do you envision, and some of the modalities, what would be your recommendations going forward?
Thank you, Walter. One of the biggest lessons we take away from COVID-19 is that even those privileged ones that had money to go and get treatment out of the country, they now have to bear with what is available for everyone else. And what does that tell us? We need to improve the system that we have. We need to have financing for it. We need to have commodities. We need to have health workers. And we need to have a facility where we can go and we are happy and we can afford. And therefore, the very first thing is for members of parliament to pass the National Health Insurance Scheme, which is one of the modalities to finance health in this country. Secondly, we need to invest in, as Dr. Kadama has said, and also Professor Waiswa, participation of the consumers, of the masses, is really important and can't be underestimated. I'll just give an example. I was talking to my sister in Kalisizo, and she's desperate. She doesn't know what's happening. People, I think the information that is seen on TV, in the communities, it seems like they have taken this disease for granted, and they're moving on to do what they want. What does that mean? Leaders should get down to the ground and ensure that the users, the people they represent, are getting their voices heard, and that they know exactly what's happening and the implications. So that's really important, getting the consumers to participate and also feel accountable. Collaboration will be very, very crucial, as has been said by also Dr. Tony. One of the things we need to do, especially if we have to see local production advance, is to have collaborations with universities that's where all research happens. And the very good thing right now is that there is a collaboration within the Ministry of Finance and Makerere University to do research. Can we see new medicines coming from this research? Can we advance our traditional medicine using this medicine? And can we see that we reduce the reliance on the medicines coming into the country? But also, government needs to put a lot more money into health. At the moment, when you talk about commodities, even with the money of donors combined, we can only meet half of the medicine needs of the country. What does that mean? First of all, we need to engage the communities deeper to reduce the infections, because most of the burden we have are diseases that can be prevented at household level, as Dr. Kadama said. Once that comes down, then the overall need for medicines will reduce. We also need to engage other stakeholders, other ministries, for example, ministries of gender, the police, because, you know, health cannot stand without the other sectors. Thank you very much, and over to you.
All right, thank you, Dennis, and thank you for your contribution to this conversation. We'll head straight back to the studio, and I want to take parting shots from, you know, both my panelists here. I will start with Dr. Kadama. I want to understand something from you, and this is really to pick your mind. The Ministry of Health received, during this time, COVID-19 emergency response, received, you know, more than 100 billion for, you know, preparations and, you know, buying the PPEs and, you know, putting out communication and all those things within COVID-19. And they still say they want more money. You have served. You're now enjoying the service. Is it really about money?
No. We used to be taught, I think it's not taught this way these days. Money is not a resource. Money is a medium of exchange between goods and services. So basically, as you heard, the spokesperson from the ministry said, oh, we have plenty of masks, they have plenty of PPE. So what is the problem? Why are the PPEs not in that health center in Alegu, where that gentleman was examining the old lady of 80 years with COVID? Something breaks down. So what needs to be done now is to ensure that we are properly organized, that we lobby for public policies that are effective, that private gains should not obstruct public policy and public gains. For instance, I've heard, this is just, by the way, I have not seen it properly published, that the cost of doing business in Uganda has been a great hindrance to launching the health insurance scheme. This is now private gain standing in the way of public gain. And here what we are talking about would be the cost of doing business in order to have a profit, to break even. You would be sacrificing a public gain for a private gain. That situation lands you in the situation we are, where you do not have an essential package of services close to you, walking distance for you, in order to be deferred for other services. Whether you use border or you get on a plane to go to Germany, all of us are grounded. Those who fly to Germany and India, those of you who get border to go to your health center, we are grounded. The only people who were not grounded were the people who can walk to their health center, and where the health center was able to deliver the emergency services that are basic and essential. This is what we have now got to be doing today to move forward. How do we get these integrated packages of services, integrate the new modalities that we have learned in COVID into maintaining the supply of what we call essential basic services? And that is how we'll be able to go forward. That will require us to make coalitions, to engage other sectors, to ensure, one, that workplaces are safe, people are healthy and are not going to contract disease where they work. Two, that in the household they have basic hygiene and they are also healthy. That in between the household and the workplace, that is the in transit or transport, is equally as safe. They can go to work and come back home safe. That way we shall be able to move forward with any new modalities or any new money that becomes available will be used more efficiently and effectively. Merely accumulating funds when you have not planned the exchange of goods and services for a service throughput does not benefit you.
Thank you very much. Clearly put, it's not about money. Dr. Tony, we are definitely going to move out of COVID-19. Time will be there when we'll have to move out of COVID-19. But the disrupted services may have a long-lasting impact, in the future. How do we harness the two to ensure that, we'll have an almost smooth transition from the effects today and the effects tomorrow after COVID?
Okay, again, the scenario we've been in is not new. COVID is new, but the scenario we were thrown into is not new. We've had epidemics before, and there is a way that we transition. What is very critical is that during the crisis period, the emergency period, you respond to the crisis, but also ensure certain essential services continue. And that is based on, the continuity of services is based on an existing structure, the health system that's in place. So that's the good news. We have a system in place, and there was an attempt to ensure that essential services continue. The disruption came, and we seem to be getting over it. So it's very important to remember that as we get towards the end of this, we begin to strengthen those components of the services that have always been going on. Of course, I speak for mothers, newborns, and general reproductive health and child health. So if we had this cascade, the continuum of care for antenatal care, we have to go for, the women have to go for several visits, at least 4 in Uganda, but more than that is still okay. Then there are details of when do you come even for first ANC. I had Florence from Kabale talking about the numbers reduced for first ANC visits, but there is also the component of when do you come, because you might come within, you might come for first ANC, but it's a bit late. There is what we call the first trimester, the first 3 months. So all those things, the systems have been in place, and we need to just pick it up from there. I remember at the beginning I painted a picture and the targeted interventions for the RMNCH situation in this country. So we just need to pick it from there and move on. But if I'm to, of course, COVID has been very sad, really. There is this lady, 30-year-old, who went into labor somewhere in Wakiso, Chira to be specific, on the 19th of April. I picked this story through one of our partners, the White Ribbon Alliance. Very sad story, and I'm sure there are others like that that may have not been picked. So she actually ended up dying because there was a delay. We talk about the delays. First, to even think that you need to seek a service, then to actually access the service. So transport this time was a big problem. We're under total lockdown. And by the time she got to the health facility, it was late. She was rushed to Rubaga Hospital as a referral. Baby came out already dead. She also passed on, unfortunately, later. So those are sad scenarios, and they should actually motivate us to think that, okay, when we get to normalcy after this crisis situation, let us do the things that we have to do correctly. There is offering a service, but is it of quality, for example? Quality is defined as giving the correct service, the right service, at the right time and in the right way. So we have to look at those aspects as well. And if I can just maybe list things that I would think would help us transition well, given that COVID is still perceived to be around and we have to respond to it, then we have to ensure that the mothers and their newborns are safe. They should not acquire it. That's one. And that calls on interventions on either side, the demand and supply side of the service. Yes, the PPEs and the others. I wouldn't go into that because we already talked about them. Then two, let's ensure that the backbone of the system that we're really building should be picked up again and strengthened even more, so that we have not only continuity of these MNH services, that's maternal newborn health services, among others, but have them more robust post-COVID, period. Because we have the capacity actually to do so. At times, I think accountability issues here and there, which I don't want to go so much into, we all know them, but let's be more robust this time post-COVID, so that all preventable death should be prevented. And indeed, most of them actually can be prevented. Then thirdly, there is the issue of partnerships. I'll not say much into that, but let me just throw this. There are what we call social determinants of health. Professor Omaswa from Achest is famous for saying that health is not made, I think, at the health, it's made at home. It's only fixed at the health facility. And that's very true. So there are social determinants: nutrition, housing, security, even up to the mental. Actually, health is defined as not just the mere absence of disease in your body, but even how are you mentally. All those aspects define health. So we need to ensure that the partnerships bring on board to cater for the social determinants of health. Ministry of Agriculture, Ministry of Defense, and all those things. It is a social, collective contribution towards health, not only the Ministry of Health. Then the fourth one is looking at, is that the fourth or fifth? Probably the last. Let's ensure that the messaging is correct. We've had cases of people are not aware what is COVID in the villages, and yet messages are actually going out. I see so many from NTV here, messages coming out, but are the people understanding? How are they packaged? Let's ensure that the messages are simple, simplified. If possible, translate them to the languages that people can understand, and that includes both COVID messages and also maternal newborn health messages, family planning, and all that. Simplified. Let's demystify these terminologies of family planning. They're just two words: family and planning, and it can mean anything that relates to that. So messaging is very important. And then, lastly, let's handle the two together as we transition. And I'm sure the capacity is there in this country. Ministry of Health is strong. Together with partners, we can do this. And if I'm to say my parting shots?
Yeah.
Yes. I really want to say that I appreciate, I think, the possibility to be on this platform, made possible by funding from the Ministry of Foreign Affairs, Netherlands, through our health system advocacy partnership project, where ACHEST and HEPS and AMREF have been working together for almost 5 years now to push forward the agenda of advocacy for SRHR. So we are grateful for that, and the partnerships have been good. To the health workers, I say I'm one of those who migrated, but internally, from clinical service to public health aspect, but I'm still around. So to the health workers, thank you so much for the sacrifices that you make. And I think to you, the media, you play a big part in this. And thank you for hosting us.
All right, thank you very much. That's it for today. And of course, from my panelists, Dr. Patrick Kadama, the Head of Policy and Strategy at the excuse me, African Center for Global Health and Social Transformation, CHEST. We had Emmanuel Aineviona, the spokesperson from the Ministry of Health. He had to leave earlier. And Dr. Tony here, Kapsandui, the Program Manager, Reproductive, Maternal, Newborn, Child, Adolescent Health, yes, and Nutrition at AMREF Health Africa, Uganda. And our colleagues online, Dr. Peter Waiswa, Associate Professor of Health Policy and Planning Management at the School of Public Health. We had Chris Ongom from Lira. We had the District Health Officer from Lira, and Florence, the Executive Director, Kabale Women in Development, who all made a really, really great contribution to today's engagement. And we hope that you, the audience there, who is very key in this engagement, you have picked one or two many things from today's discussions, and of course you will be able to use the information that you have achieved today or you get today to make your next decision on how and when to receive a health service when you need it. What we still know is that COVID is still around with us, so we must adjust and learn to live with COVID-19 around us, simply by following the measures put across by all these international bodies, including our own Ministry of Health. Have your mask on if you're going to the public, and wash your hands with soap and water, or with a alcohol-based hand rub or sanitizer. And of course, if you have the symptoms or you feel the signs, please don't move around, don't go to the hospital. Call the contacts provided by the Ministry of Health, and you will be helped. Thank you very much for tuning in this afternoon. We will now return you to normal programming. Have a very good evening.